thank you for coming to the talk. And what I'll be talking about today is colorectal cancer, the role of surgery. I have no disclosures. In this talk, my colleague, who's a colorectal surgeon, Dr. Hunter, also gave a talk last week, and he talked, and so we kind of, there'll be a little bit of overlap if you were at last week's talk, but at the same time, it's sort of different because both of us have different roles and kind of different specializations. So the objective of this talk, we'll do a little bit of an introduction. We'll talk a little bit about detection of colorectal cancer and the treatment. And the treatment is kind of very different based on the stage. And we'll kind of focus on that, the treatment of colorectal cancer through the various stages, the role of surgery, the role of multidisciplinary management, and then we'll sort of come to some conclusions. Dr. Hunter is a colorectal surgeon primarily, and so he often, his focus is treatment of the primary cancer. I'm a surgical oncologist by training, and so there, which basically means cancer surgeon. But my focus is a lot of metastatic colorectal cancer. So that's the bulk of what I treat in colorectal cancer is metastatic disease. And so he focused his talk on treatment of the primary, and mine will be focused on the treatment of metastatic disease. But as we know, March is Colorectal Cancer Month, and so it's important, and that's why we're here, and that's why it's a good time to sort of focus on the subject. And so just as a little refresher, your colon kind of starts on the right side in the right lower abdomen almost, and then goes upwards, drapes across the abdomen, comes back down, and then continues on to your rectum and then the anus. And so any cancer anywhere along this area up into the rectum is what we call colorectal cancer. Your liver sits up here, and we'll talk about when cancer spreads to your liver or to other parts of the abdomen, what can be done as far as treatment. What I'm going to do, I don't know if we can, hey, Lindsay, I'm not sure if we can make this a little bit interactive. It's harder when it's on Zoom, but I can stop potentially after each sort of subsection. And if there are questions, I'm happy to answer them, or we can just take questions at the end, whatever works better. What I don't want to happen is you have to wait on a question and then you forget, but I'm okay with either. I'll stop after sort of the first half of the talk. So a little bit of introduction. Colorectal cancer is common. These are the numbers for 2020. And so it is the fourth most common cancer in 2020 with over almost 150,000 new cases. And it is the second most common cause of cancer-related death, just after lung, but higher than pancreas. These are some more numbers. Estimated new cancers in 2020, again, close to 150,000. Estimated deaths, close to 9% of colorectal cancer, of all cancer deaths. And if we look at this graph, we can see that, I mean, the numbers are still high, but there is a downtrend because we are actually doing somewhat better now overall than we did before, both in terms of incidence, meaning the number of new cancers, as well as the death rate. And so we've gotten better at treating it, but we've also gotten better at screening for it, which is why this graph kind of heads in the right direction. It heads lower. Overall, the 5-year relative survival is upwards of 60%. And if we look at, so those are national numbers. If we look at local numbers, Alabama, Mississippi have a higher incidence and a higher mortality. So our numbers are worse than the national numbers. So if we look here, Alabama and Mississippi compared to the US, this is men and women, and across races, the incidence is higher. So for white men, the incidence is 50. This is per 100,000 compared to 46. For Black men, the incidence is 65 compared to 58. The same thing with women. The incidence tends to be higher in this area compared to national numbers. And the same thing goes for mortality as well. So it's important that we talk about it, it's important that we find it early, and important that we sort of know what our treatment options are. So in terms of risk factors, age is a risk factor. There is the risk of multiple cancers, not only colon cancer, increases with age. We also know that specifically in colorectal cancer, we've been finding it more, that the rates are going up in younger patients though. And so that's something to, it's not only a disease of sort of older patients. Race is an important risk factor. So African Americans have a higher risk of developing colorectal cancer. They also have a higher mortality from colorectal cancer once developed. And there's a higher incidence of developing colorectal cancer at a young age. This trend has been seen across races, but it is somewhat higher in African Americans. There are multiple sort of modifiable as well as non-modifiable risk factors. And some of the modifiable risk factors are diet. So we know that a diet that's high in red meat and processed meats is associated with an increased risk. All these risks are not, so they're not several times the risk, but all of them can add up. And so tobacco is associated with a higher risk of developing multiple cancers, not just colorectal cancer, as well as alcohol is associated with an increased risk of developing colorectal cancer. And then this slide is sort of based on your non-modifiable risk factors. So a personal history of things like inflammatory bowel disease, ulcerative colitis and Crohn's both predispose you to developing colon cancer. Any prior abdominal or pelvic radiation, particularly in childhood. Obesity, especially early adulthood obesity, is associated with an increased risk of developing colorectal cancer. There's a slight trend towards increase with diabetes. And then family history is important. About 10 to 30% of patients who develop colorectal cancer have a family history or have some form of hereditary reason that their risk is increased. So there are hereditary colorectal cancer syndromes, and I know my partner talked about them in quite detail last week, so we won't really talk about them except to say that there is increased risk, and therefore the screening recommendations and the treatment recommendations are different if you have a hereditary colorectal cancer syndrome, or if you have a family history of colorectal cancer. Particularly a first-degree relative, and especially if that first-degree relative is diagnosed under 50 years of age, screening recommendations change and sort of the risk is higher. This is just a little slide to show that we do, so for any patients who have a family history or a suggestion of a family history, it's important to talk to your doctor about it, and they may recommend genetic counseling. This is important for anyone with a family history, particularly a first-degree relative. And it's a service that we offer at USA. You don't have to have all the rest of your treatment at USA to avail of the service. I have some patients who get some of their care elsewhere and have seen us for other reasons and come see the genetic counselor, who's very good. And it's an important service, I think, that we provide. So in terms of how do we find out? So you can have symptoms, but ideally the reason our incidence has gone down is because we've gotten much better at screening. So in detection, I would say screening. The symptoms, so what are the symptoms? Patients sometimes present with blood in their bowel movements, narrower stool, sort of change, what we call change in caliber of the stools, a change in bowel habits, so more constipation, a feeling of incomplete bowel emptying, abdominal discomfort, weight loss, fatigue. Weight loss, particularly if one is not trying to lose weight. So unintentional weight loss is usually a sign that we need to figure out what's going on. Patients could have fatigue. And most often, a large number of times, and this is kind of how we want to find it, patients are asymptomatic and it's found on screening. So this is the ideal way to have this found, because screening does multiple things. And I know my colleague talked about it in detail, so I won't belabor the point, but it's important enough that I felt we should talk about it at least a little bit. Screening can be done sort of through multiple ways. Why is it important? Because we can find cancer at an earlier stage before patients become symptomatic. The reason the incidence of colorectal cancer has gone down through the years is because, importantly, it helps us to find precancer. And so if one has a screening colonoscopy, and important to know, the recommendations have changed. So now the age at first screening is 45, which is a new change over the last couple of years. And so we can find precancer. So the gastroenterologist or the doctor doing the screening colonoscopy may find little polyps that are removed, and those polyps can over time turn into cancer, but now they're removed before you turn into cancer. So if the polyps removed before it's turned into cancer at all, there is no difference in overall, the prognosis would be as if one never had cancer in that area. And so it reduces the incidence of colorectal cancer by finding precancer. It also reduces the mortality of colorectal cancer by finding cancer at an earlier stage. So bottom line, screening saves lives. Screening is super, super important. It's not something that most people love to do, but it's important. But it's so important because it makes such a difference overall. And this picture kind of shows why. So what we want to do with screening is we want to find patients in this stage here. Stage 0 would be great. Stage 1 is also, we basically want to head to the left side of this. So the way we define stages kind of depends on how the tumor is spreading through the layers of the colon or the rectal wall. And so stage 0 is kind of the tumors at the very first little layer. Stage 1, it kind of breaks through that first layer. Stage 2, it goes somewhat deeper. Stage 3 is when it goes to the lymph nodes. And stage 4 is when it goes to other organs. And so our goal in screening is to find patients here. And so we want to find patients on this side of the screen, because once it goes to the lymph nodes, it's sort of broken the barrier off the colon. It's gone elsewhere already. Once it goes to and then from there, it sort of goes to other organs. And so this chart, I won't belabor this point, but there are multiple ways one can be screened. Not all screening tests are equal. The colonoscopy is sort of your gold standard. The recommendations are every 10 years. Recommendation is to start at age 45. The sensitivity is high. So the sensitivity is how it detects disease. And so it's very high, higher than most other things. And it also picks up advanced adenomas better than sort of any other modality. And so that's one of the things to know is that most other tests, while they may show you cancer, they don't pick up precancer quite as well as colonoscopies, unless they're big, in which case a CT colonography can sometimes help with that. And then you have to go back, if you see an adenoma, you have to go get a colonoscopy anyway, potentially, to have this evaluated and then potentially removed that way. Do we have any questions about screening before I move on? I don't know if I'm not seeing them, but I don't see anything in the chat, so I will keep going.
We did get one question.
Okay, yeah. So I have see a question. Since I've had bariatric weight loss surgery, does it affect the screening? No, it wouldn't. Thanks, Kathy. This is so a screening test, depending on the screening test you have, a colonoscopy or any of those other tests, it wouldn't affect how your screening is performed. It wouldn't affect sort of the sensitivity of it, how well it's done, or how frequently you have to do it. We talked about weight loss. So weight loss, if it's intentional, as in your case, if you lost weight after your bariatric surgery, that's sort of different. But if you people who lose weight when they're not trying to, that should be sort of a little bell going off for someone needs to work that up. Do you think they might come up with an alternate way to prep? There are multiple ways. If you've had your bariatric surgery very recently, then that might be that might take a little. It takes a little while before you can go back to having where you can drink your prep, but as long as it was a little bit in the past, it shouldn't matter, and you can do a slower prep. All right. I'm going to minimize that for now, and we'll move on. And we can talk a little bit more about that sort of later on as well. Okay, so treatment. So the treatment of colorectal cancer depends on the stage, essentially. In general, the earlier the stage, the less we need to do to get it out. So the less aggressive the treatment. When we talk about treatment, that will be for all stages a combination of either a surgery or a procedure to take out the cancer, with or without chemotherapy and with or without radiation, depending on whether that starts in the colon or the rectum and what stage it's at. So the first thing we need to do before treating is to find out what the stage is. And the way we do that is you want to evaluate both the cancer, you want to evaluate the cancer locally, and then you want to evaluate for spread of cancer. So the way we evaluate cancer locally is either if you've had a screening colonoscopy, or if one has symptoms and you've been to a GI doctor, and the GI doctor will do an endoscopy, so a colonoscopy. And that will evaluate the cancer locally, meaning they'll be able to see it. And then we'll want a CT scan of the abdomen and the pelvis. And that will help us look at it both locally as well as look elsewhere in the abdomen and pelvis to make sure to look for lymph nodes, to make sure there's no evidence of spread. If the cancer started in the rectum, then we also get an MRI of the pelvis, because that helps us to see the layers of the rectum better and to see to know whether it's to look for spread into sort of the surrounding pelvic wall and lymph nodes. It's a much better imaging test. And so for rectal cancer, we get an MRI. And then the other thing we want to do is for any cancer, you want to look at it locally to see what the anatomy looks like locally, and then you want to look for spread. And so to evaluate for spread, the CT abdomen and pelvis helps with that, because we get to look elsewhere in the abdomen. We get to look at the liver, the inside of the abdominal cavity, and then we also get a CT scan of the chest to make sure it hasn't spread to the chest. And so this is sort of just a general overview of what we do. So either a patient will have symptoms that have led to a colonoscopy, or this is found in a screening colonoscopy in which they don't have symptoms. That evaluates the tumor or the polyp, which is then removed. If it already looks like a cancer, then they will often biopsy it. If it's a polyp, sometimes that polyp is removed, and then the pathologist looks at it. And if they find cancer on it, so if the cancer is either seen through colonoscopy and biopsied, or removed and found on a removal of a polyp, the next step is to get imaging. So we'll do the imaging like we talked about, where you get the CT of the abdomen and pelvis, as well as the CT of the chest. If it is rectal cancer, you'll get an MRI of the pelvis, but not otherwise. And then we present this every case at a multidisciplinary tumor board. And so what does that mean? So there's a group of us who sit in a room, and now we do it via Zoom for the past year. But there are surgical oncologists, so cancer surgeons like me, colorectal surgeons who treat cancer but focused mainly on the colon and the rectum, medical oncologists, radiation oncologists, the radiologists who help look through the scans, the pathologists to discuss the pathology, as well as genetic counselors. So there are multiple people in the room. And these, at bare minimum, these are the people in the room, but there are multiple other sometimes people in the room, and we talk about each case and get consensus at the tumor board about the best potential treatment option. Because cancer is not, all cancers are not equal, so to speak, and every cancer is sort of different. And so it's important to treat the patient and decide on the best treatment option for that particular cancer and that particular patient. But in general, treatment, like we said, depends on stages. So I keep referring back to this picture. And so the treatment will differ whether you're here or you're stage 1 through 3, where it's local and hasn't yet spread to other organs, or if it's stage 4. And we'll talk quite a bit about stage 4. So if the cancer is found at a stage 0, so it's pre-cancer almost, or stage 1, early stage 1 cancers can sometimes be removed locally. So this is where a patient had a polyp, and the polyp is being removed, and the polyp gets sent off to the pathologist to look at, and sometimes they find pre-cancer here, and sometimes there is early stage cancer here, and that may be all that's necessary. Can also be done, this similar procedure can also be done when it's lower down, but it's also a local procedure where this area is removed and then closed up. But that can only be done for stage 0 and some stage 1s. For other stage 1s that are slightly deeper, or stage 2s or 3s, what we end up doing. So 3 again is spread to the lymph nodes. And so what we end up doing is you have surgery, regardless of where that is. So if it's in the rectum, the surgery is a little different. If it's in the colon, depending on the side, the surgery may be a little different. Again, I know my colleague went into this in quite a bit of detail last week. So we won't talk about that portion of the surgical treatment again, but the treatment is surgery plus chemotherapy if you have a stage 3 cancer. And then sometimes in some stage 2 cancers. And this chemotherapy is usually given after surgery, but not always. Sometimes in stage 3s, you get the chemotherapy before surgery as well. And then radiation is given for rectal cancer. It's usually given before surgery along with chemotherapy. Sometimes if the tumor is thought to be at a lower stage, then you may have surgery first, and then when the pathologist looks at it under the microscope, they find that it's actually a slightly higher stage, and then you'd get the radiation after surgery. But otherwise, it's usually given before the stage 2 or 3 rectal cancers. And then stage 4, and the rest of this talk will focus on treatment of stage 4 disease. And so stage 4 colorectal cancer is metastatic colorectal cancer, meaning this has gone somewhere else outside the lymph nodes, but it's gone either to the liver or around elsewhere in the abdomen or to the lungs. And those are the 3 most common sites where it spreads. And so how we treat that is a combination of chemotherapy, and here the chemotherapy will come first, plus surgery or some other local regional therapy. Sometimes you can have surgery for both the primary cancer, meaning the cancer in the colon or the rectum, as well as the metastatic cancer, meaning the cancer that's spread to the liver or to the lung, particularly if it's the liver, because this is the same abdominal cavity. And so sometimes you can have surgery on both places. There are caveats to that, but we can talk about it. When we talk about stage 4 or colorectal cancer, this is associated with a lot of sort of anxiety in patients, right? Because stage 1 through 4, and no one wants to be stage 4, and that is, it is true in that we want to find patients earlier. The treatment is easier. It's often less aggressive. The overall survival tends to be better, but we have made substantial sort of improvements in the treatment of colorectal cancer, metastatic colorectal cancer over the past several years, and it's important to know and sort of talk about. And so 50% of patients who have colorectal cancer will develop metastatic disease or stage 4 cancer over the course of their lifetime. So 50%, about half. The most common sites are the liver, the lung, and the lining of the abdominal cavity. The liver is the most common site. About half of patients will develop metastatic disease here. It's the most common cause of mortality. It's the most common reason patients die from colon cancer. But those are all bad things, but it's not all bad. There are lots of things to know about the liver that make it so that there are many treatment options for this type of cancer. So one of the important things is the liver regenerates. We know we can take out up to 70 to 80% of a normal liver in surgery, and patients will do fine because the rest, the remnant liver that's left behind, that 20 to 30%, will can take over the function of the rest of the liver and can grow back over time. And so metastatic disease or stage 4 disease is resectable. We can take it out, and it is also potentially curable. And that's important to know because I mean, this is a lot of the patients I treat are metastatic colon cancer. And it's important because a lot of people don't really realize this. And we used to not think like this 20, 30 years ago, but over the course of the last 20 years, the tools we have in our armamentarium have increased significantly. So why resect metastatic colon cancer? And I'm going to say colon cancer, but I mean colorectal cancer. We know that untreated patients, the 5-year survival is less than 5%. We know that when we treat this with curative intent surgery, meaning we're trying to cure you with a combination of chemotherapy and surgery, that 5-year survival increases to between 50 and 60%. So significantly better. And so it's important to know that, and treatment is important because it improves survival significantly. So how do we define, we talk here about resectability and curative intent. So how do we know that something can be resected? How do we know that we're helping patients? What criteria do we use to take out tumors in the cancer from the liver that spread from the colon to the rectum? And so all these things come up, and all of them are relevant, but none of them are, there is no size cutoff. There is no number beyond which you cannot have attempted cure. So the things we look at, and all these things come together to essentially to help us make a decision about how we should treat. But the things we look at are, to some extent, tumor size, number, what the primary cancer is, where it is, and how it's, what stage that is, what T stage or tumor stage that is at, what tumor marker numbers are, is there other spread of disease elsewhere, what is the condition of the underlying liver? And we'll talk about each of these. So how do we define resectability? This is a chart that I sort of changed a little bit to make it easier to read, but it basically talks about what our criteria are. So any number of tumors, it doesn't matter if the number of tumors is 2 or 8, that does not determine whether or not you can have curative intent resection. Any size of tumors, so it doesn't matter if the tumor size is 2 centimeters or 8 centimeters, doesn't make a difference in terms of whether you can have surgery to attempt to cure the disease. It doesn't matter what the size or extent of the primary tumor is. It doesn't matter what the tumor marker numbers are, which is not to say that they may play a role ultimately in talking about what the prognosis is, and your doctor will have, your surgeon should have a conversation with you about that. But these do not prevent or preclude anyone from having surgery to try to cure it. Because while these things are somewhat important, it's much more important to look at how the tumors are responding to chemotherapy, and because that gives us an idea of what their underlying, how they behave like on an underlying level. So what their tumor biology is like. So we talked about any number of tumors, any size of tumors, any type of primary tumor in the colon or rectum, as long as we can do a few things. So as long as we are able to get it out completely with a negative margin, as long as we are able to leave enough liver behind to take over the function of the rest of the liver, so that is 20 to 30%. As long as we are able to maintain the liver blood supply, and as long as we are able to maintain the bile duct continuity, because your liver makes bile, and as long as we are able to maintain that, patients are able to have surgery to try to cure this. this just says sort of something a little bit subjective, but it says well-selected patients, and that kind of refers to how, so when, if there is disease elsewhere in the liver, that also elsewhere outside of the liver, that doesn't prevent you from having surgery. So what well-selected essentially is saying is it depends on how the tumor is responding to chemotherapy. And if we are able to take out this disease outside the liver as well, that is helpful. So basically what this boils down to is that each patient, we take a tailored, a personalized approach to each patient. There is no number or size criteria that we use. So how do we treat it? All cases of, anytime someone comes to see me in clinic or to see one of my colleagues in clinic and they have metastatic colon or colorectal cancer, all of them get treated and all of them get discussed in a multidisciplinary forum. All of them will get treated with chemotherapy and surgery, and that's important. And the sequence of it is important because they both surgery and chemotherapy do different things. So once the cancer is already spread, and we know it's spread to say, let's say the liver, we know that little cells have broken off and are going to other places. And so you need a treatment that treats all of you. So, and that's what chemotherapy does. It treats the whole body. And then you also want a treatment that treats locally. And that's what surgery does. It treats locally. And so this combination of things is tailored to each individual patient and how that tumor is responding to the treatment. So when we talk about surgery for metastatic colon cancer, so if a patient comes in and they have a tumor in their colon and it is spread to the liver, now there are two areas that need surgery, right? But we start with the chemotherapy. We present the patient. We start with the chemotherapy, and then when you need surgery, when it comes to surgery, that means two different surgeries, which can sometimes be done on the same day. So this is talking about the liver aspect of metastatic colon cancer. Once it's spread to the liver, surgeries can be done either open or minimally invasive. Minimally invasive surgery could either be laparoscopic or robotic. Both have certain advantages. When we talk about minimally invasive surgery, nationally, less than 10%, less than 10 to 15% are done minimally invasively. Most often these are done for non-major hepatectomies, meaning not the cases where we have to take 60% of the liver. These are usually done for smaller liver sections. It is associated with a shorter hospital stay. So particularly for smaller hepatectomies where one does not have to have a large amount of their liver removed, doing this in a minimally invasive fashion, either robotically or laparoscopically, is associated with a slightly shorter hospital stay, about a day less in the hospital, and this faster wound healing. There's no difference in complications. And we do a lot of the non-major hepatectomies this way. Open surgery tends to be reserved for either the major hepatectomies or if for surgeries for tumors that are in quote unquote difficult locations. So if surgery in the liver is not so much defined by how big the tumor is, but by where it is. So based on the location to the important blood vessels. So for those kind of surgeries as well, we often do them open when they're difficult because they're very close to important blood vessels that we need to preserve. But what about all these things that we talked about earlier, right? So how do they matter? So we'll talk about them one by one. So tumor size. So size really does not matter. There is no size cutoff. Like we said, the location next to the blood vessels is far more important than the size. And what that means is this. So when we think of the liver, we think of an organ that looks like this, right? But it's not really like that. In reality, it looks like this. Well, you can't see any of the vessels on the outside. There is a big blood vessel that goes in from here and splits into two, and that's the major blood supply that goes to the liver. and the major blood supply that goes out of the liver is this, your IVC. And so there's no size cutoff. A larger tumor, say here, is much easier to resect, and then say a much smaller tumor that's right here next to this blood vessel, or right here next to where this blood vessel bifurcates. And so the location is much more important than the size of the tumor. And the response of these cancers to chemotherapy is much more important than the size as well. And that the response to chemotherapy is reflective of the underlying aggressiveness and the underlying type of tumor that it is. And so that's far more important than size. What about number of tumors? So more tumors does mean, hello? Did someone say something? All right, I'm going to keep going. So more tumors does mean more disease, but there is no number cutoff. So just because someone has 5 tumors, that doesn't mean that they cannot attempt to have curative intent surgery. And again, the number of tumors, the response of tumors to chemotherapy is much more important than the number of tumors in the liver. And so what happens, where did I do that? Here. So what happens if one has multiple tumors here and here and here, and say one on this side? So then how do we deal with that? So there are many ways to do surgical resections. We can sometimes, when it's possible, we can take them all out. If there's more than one, obviously, we can take them all out at the same time. If it's possible to fit all those criteria. So we take them out completely, and the liver, there's enough liver left behind, and we haven't impacted the blood vessels, and the blood vessels are able to supply the liver, and the liver's able to make bile, which then drains out the bile duct into the bowel. But what if that is not the case? What if we had to take out all the tumor, there would be not enough liver left behind? And we have ways to deal with that that have been used for a while now, and patients do very well with it. And so one of the ways we can approach that is a 2-stage resection, and we'll talk about what that is. And another way we can approach that is by combining resection, sometimes with ablation. Sometimes when there are small tumors, say elsewhere, and by small I mean less than 2 centimeters usually in size, those tumors can also be ablated in a combination with surgery if required. So what does 2-stage resection mean? Let's say this is, this is a cartoon, but let's say this is where the tumors are. And so there are tumors all over here on the right side, and then there's this tumor here. And so the only area, particularly if there were, the only area that would be left would be this little area. And so what we do in a situation like this is we would like to leave half the liver behind if we can. We would like to leave, let's say, this whole left side behind if we can. And so patients will get chemotherapy. So this is actually the line dividing the liver into right and left, even though on the surface it looks like this is. So patients will get chemotherapy. And then what we can do is we can, quote unquote, clear the left side of the liver by taking out this little tumor from the left side. And so once we take that out, then there wouldn't be any more tumor on this side of the liver. Our next step then is what we want to do is we want to increase the blood supply to this side of the liver, because as we know, the liver can regenerate, the liver can grow and can take over the function of the other side of the liver if needed. And so once we get some chemo, and once we take this tumor out, then what we can do is we can block the blood supply to the right side of the liver. And what that does, it makes the left side of the liver grow bigger. And once that happens, the amount of liver that we're left behind with, which is this side, has now grown much bigger over time. And so we can take out this side of the liver fairly easily, and the remaining liver, or we call the liver remnant that's left behind, does well. And it's already proved that it can take over the challenges because it's grown on its own because we blocked off the blood supply to the other side. That's complicated. I know that's hard to explain, but I have CT scans and we can talk about it a little bit more. So that's one of the ways we treat metastatic colon cancer when there are multiple tumors in the liver. And so this is kind of shows that. So these are just pictures from a CT scan. A CT scan kind of goes through you from head to toe, and as if you are sliced sort of horizontally this way. So each slice corresponds to we're going lower and lower. And so here, one can see the liver. You can see the stomach up here. This is one of the blood vessels that we were talking about. And so this patient has a big tumor sort of in the middle of the liver and another big tumor down here. And so if we go to the previous picture, that would correspond to a tumor here and a tumor here, leaving behind only this little portion of the liver, which is usually about 20% of the liver. And so sometimes it can be as little as 10%, like in this patient. And so we can't leave behind only 10%. So we'd have to do something to ensure that this patient had enough liver left behind after we took out these tumors. And so first she got some chemotherapy. And after the chemotherapy, we can see the tumors shrunk a little bit. They look different. And the way this changed is exactly how tumors are meant to look after they respond to chemotherapy. So they actually even look different on scan. And so here you can see they're sort of hazy and fuzzy looking. Here they look much clearer and you can see them much more defined. And that is a change that is associated, that it often represents a good response to chemotherapy. So we know she's had a good response to chemotherapy. They got a little smaller. So how much liver will remain after resection of the right side of the liver? And she actually had just about 10% that would have remained. And so this area, so what the next step was then to block off the blood supply to this side of the liver, to the right side of the liver. And we do that because of the blood supply, just like this is essentially a preparation for what is to come. So if we took out the right side of the liver, the left side of the liver would grow. We know that. But we know that what she has left behind, or the initial 10%, was not going to be enough to survive. And so in preparation for that, we blocked off the blood supply to the right side of the liver. So now the left side was a little bit realized that it needed to take over the function of the right side already. And so the left side grew. And so after this is called a portal vein embolization. So that big blood vessel going into the liver that we talked about that splits into two is called the portal vein. And so what we do is we block off the blood supply to the branch of the portal vein that is on the side that we plan to take out. And so the other side of the liver gets bigger. So before blocking up the blood supply, the amount of liver that she had was only 10%. After blocking up the blood supply, this area grew, and now it grew to 33%. And we know that you need between 20 and 30% of a liver in order to survive. And so, and in order to tolerate the operation. So now she has over 30%. And so then she had surgery. And the surgery that she had took out, I'm going to go back just to show you on this picture, took out all of this. And then she was just left with this portion, which was initially only 10%, but now it's 33%. And she actually had a great response. The tumor was completely taken out, and most of the tumor had actually responded to chemotherapy. So overall, that is exactly what we hope for when we treat this kind of tumor, this kind of cancer. I made this talk a little bit short because I assumed there would be questions about this. I know it's sort of difficult to think about, but we'll talk about it some more at the end, and I'm happy to answer whatever questions come up. But just moving on a little bit, in terms of when we see that picture where we have tumor size and number of tumors and the other thing, what are the other things we think about? So what about the primary cancer? because when one has metastatic colon cancer or colorectal cancer, now there are two tumors that need to have surgery. There's the primary cancer, and there is the cancer that spread to the liver. And so how we treat those, the timing of the resection varies. Sometimes we take out the primary cancer first. All of this is along with chemotherapy. But sometimes we take out the primary cancer first, and then the patient gets some chemotherapy, and then we take out the metastatic cancer, the spread to the liver. We often do that, this approach, when patients have a primary colon or rectal cancer that is almost obstructing, or they have, or maybe they're bleeding from the cancer in the colon or rectum, and so then it's important to deal with the symptoms, or there's a lot of pain, and sometimes it can be important to deal with those symptoms, and therefore we take out the primary cancer first. Sometimes we take out the liver cancer first, so the metastatic cancer, and then go back and take out the primary cancer. Most often we do this if we are concerned that the liver cancer is, the liver cancer might get bigger, excuse me, preventing us from doing an operation in the future, or if we don't, or if we want to limit the amount of chemotherapy that the patients are getting, because chemotherapy is really important to treat the cancer, but the liver doesn't like too much chemotherapy. It's just, it's a balance, and so we have to balance the right time to go ahead with surgery. And so sometimes for that reason, we take out the metastatic cancer first. And in some cases, particularly if both of them don't require very involved operations. So if it's not a very big tumor in the liver, it's not a tumor in the liver that require a very big resection, or it's not a very involved colon cancer resection, then sometimes we can do them both at the same time. Not always, but I would say about a third of the time, or more. Sometimes we can do them at the same time. So what are the other factors? Other metastatic disease. So whether, so that would mean if someone has tumors, say in the colon or rectum, like we talked about, so cancer in the colon or rectum, that's spread to the liver and another spot. So what if that other spot is the lung? It's still possible to try to cure patients with a combination of chemotherapy and surgery. But that would mean usually dealing with the cancer in the lung as well. That could mean doing an operation or a procedure to get the cancer out from the lung in most situations. The other thing that's really important is when we talk about metastatic colon cancer that spread to the liver, is the condition of the underlying liver, because we know that impacts what we can do. So because a lot of our treatment depends on how the tumor responds to chemotherapy and what the underlying liver will tolerate, it's important to know what the condition of the underlying liver is. And certain conditions make it so that we cannot do surgery, or we cannot do, or the liver will only tolerate a small amount of surgery. And so there are other things we can do there, but the condition of the underlying liver sometimes will limit the amount, what we can do in terms of chemotherapy and surgery. And so cirrhosis, which could be from multiple things, but long-standing inflammation of the liver from either alcohol or hepatitis or sometimes fatty liver, can all impact how much your liver will tolerate from the point of view of both chemotherapy and surgery. A history of alcohol, prolonged alcohol use, even if one doesn't have cirrhosis, can limit the amount of surgery one can have on the liver. Same thing for hepatitis B or C, particularly if it's chronic, and fatty liver, as well as comorbidities, because everything in life is a balance of risk and benefit, and I say this a lot, but one's comorbidities, heart disease, lung disease, other things that otherwise will impact potentially aggressive treatment options, play a role in the kind of treatment and what we are able to do. All right. I don't have many more slides, so I'm just going to talk about follow-up, and then we can go through questions. So once this happens, then what? So say a patient has had a chemotherapy and surgery. In general, we do a total of 6 months of chemotherapy. The way that is sequenced is very often 2 to 3 months of chemotherapy followed by surgery, and then the remaining 3 to 4 months of chemotherapy. And the reason we break it up like that is because while chemotherapy is really important, and we use it to treat the cancer, the liver doesn't really love chemotherapy. And so if it gets too much chemotherapy, it can be harder to operate on it, or at least for bigger operations. And so that's why we kind of break it up to give the liver a little bit of a breather. So we do some chemotherapy, then you get surgery on the liver, and then we finish the remaining chemotherapy after that. So say all of that has happened. So then what? Then you go back to surveillance, because unfortunately, we can't forget about it. But it means follow-up and close follow-up for at least 5 years. And so usually patients will follow up with their surgeon or with either their surgical oncologist or colorectal cancer or medical oncologist every 3 to 6 months for 2 years, and then every 6 months to a year after that for at least a total of 5 years. Most often when I do this, the medical oncologist and I will see the patients every other time, so that you're seeing both doctors, but you don't have to come multiple times to see people. The other thing we do is we sometimes have clinics in the same place. So we have a multidisciplinary clinic, so you can see the medical oncologist as well as me at the same time. But with each of these visits, you get certain things. So a physical exam and tumor markers, where we check for levels of, in colorectal cancer, we check a CEA level. The tumor marker is called CEA, and that's checked every 3 to 6 months. You get a CT scan, and so that's a chest, abdomen, and pelvis, because we want to make sure we're also evaluating for spread every 6 to 12 months, and then a colonoscopy at a year, and then after that, every 3 to 5 years. So in conclusion, colorectal cancer is fairly common in terms of cancers, but it is treatable. Important to know that even metastatic colon cancer is treatable and preventable and curable. Screening is the thing that has probably helped the most. We've made advances in terms of the types of chemotherapy we use and the types of operations we do. But the thing that has lowered the incidence and mortality the most has been screening. And that's because we can find pre-cancer as well as cancer at an early stage. When we talk about metastatic cancer, the treatment of metastatic colorectal cancer includes both chemotherapy and surgery, with or without radiation. Radiation is mostly used for rectal cancer. The treatment is personalized and tailored, so there is no sort of one size fits all. We discuss every patient, and that's multidisciplinary care, and that ensures the best outcomes. So that's all I have for now, and it is longer than I thought it would. I apologize, but let me pull up the chat and see what questions we have. All right, I see I had a colonoscopy 3 years ago, which found a tubular adenoma. I was recommended to have another colonoscopy at 5 years. How fast do polyps grow? That's a great question. So different polyps grow at different rates, really. I don't know whether that was the first colonoscopy you had with the GI doctor. In general, depending on how concerning the pathology is, they'll recommend that you come back in either 3 to 5 years. There are different types of polyps. So there are tubular adenomas, which are on the better end of the spectrum, and then there are other adenomas, which are on the worst end of the spectrum, and those patients usually will get called in sooner. I think if you're concerned in any way, then it's absolutely fine to call your GI doctor and ask them whether it's recommended that you do one sooner. If you're having any symptoms, of course, any symptoms of bowel change in bowel habits or anything like that, I would let them know immediately, and then you should have one much sooner. Any thoughts on why people are getting colorectal cancer at a younger age? That's a great question. We don't know completely why. We know that the trend is significant. We know that it is patients who are younger get a certain type of colon cancer more so than others. It's more left side. It's often more advanced, and it can be more aggressive than sort of general colorectal cancer. We don't know exactly why. I mean, all cancers are usually multifactorial. If you take out, I mean, sometimes it is related to the hereditary causes, but the sort of sporadic reason that young patients are getting it is likely thought to be a combination of diet and environment and other factors. But the honest answer is we don't know for sure. Do you think insurance companies will lower the age requirement for colonoscopies due to increasing cases in younger patients? And the recommendations have changed already. It used to be 50 years, unless you had sort of family history, and the change is now 45, and insurance companies are honoring that. And so it's important. The age has changed. It's important for people to know. And so now your first screening colonoscopy should be at age 45. With those numbers can be significantly lower, especially if one has a family history, in which case it's 10 years before the youngest family member had colon cancer, was diagnosed with colon cancer. And if it's any of the familial syndromes, then those numbers vary depending on the familial syndromes. And those are it's not usually a problem getting insurance coverage for the younger ages in those situations. That is all I see for now. Am I missing any questions?
I think you got them all.
Okay. Great.
Thank you so much. This was great.
Oh, I see one more. I have Barrett's syndrome. How often should I be? Is this for upper endoscopies? So Barrett's syndrome shouldn't impact your risk of colon cancer, but it does impact how often and depending on the type of Barrett's, how extensive it is, and what the grade of dysplasia was found, the intervals at which you'll be called back for screening will vary substantially. So sometimes it's 6 to 12 months, and sometimes it's as close as 3 months. And patients will sometimes get recommended that they even have surgery, depending on the extent of the Barrett's and what the dysplasia is. But that shouldn't, and that's something that, so I can't know how frequently you should have the upper endoscopies without knowing those two pieces of information, but it should not impact how often you need to have a colonoscopy. So it would sort of be the standard age 45 screening colonoscopy, unless you also have a family history of colon cancer, in which case it would vary. All right, well, thank you. If there are any other questions later on, I'm happy to answer them by email or something, or any other way that is available. All right.
Thank you, Dr. Fonseca.
Thank you. Have a good day.
You too.